So for me, it's about everybody in the United Kingdom with cancer getting the best possible care experience. And so it's not about everybody having the same experience, because everybody's experience has to lift up, because we are falling behind the rest of the world. Outcomes in some types of cancer are 20 years behind others in Europe now. Often people will say, well, we're working on it, we're thinking about it as an afterthought. It's just not good enough. So one of the things that lies at the heart of it for me is about how do you bring people who have lived experience of marginalisation, of cancer, into conversations with entrepreneurs and innovators early enough. So one of the things that Macmillan does is we have an impact innovation fund, which is where we invest in health startups. My name's Gemma Peters and I'm Chief Executive of Macmillan Cancer Support.
I know Macmillan Cancer Support is big in the UK. How did the organization grow to gain that support and perfect its strategy?
So Macmillan's been around for 110 years. So we existed before the NHS existed. And so we were born out of there being a massive need and people wanting to do something for people with cancer. And so I feel like right in our history is community-based, community-led work around people with cancer. And so that's always been a thread that's run through. As you say, now we're a big organisation. We've invested more than £1 billion in the NHS in terms of posts, provide support. Last year we supported 2.3 million people with cancer in the UK. You'll know there are 3.5 million people with cancer in the UK. So we're not supporting everyone, but we're supporting a lot of people with cancer in the different ways that we work. I think one of the things we're focused on is how do we make sure that we're reaching people that really need us, and that people who are having the worst experiences get the best support and get the support that they need. And I think we've really facing into the fact that we haven't always been there for communities who get the worst cancer outcomes, who have the worst cancer experience. So whether that is because of their gender identity, whether it's because of their race and ethnicity, whether it's because of where they live, whether it's because of their cancer type, sometimes whether it's because of their existing, they've got another health condition or they've got a disability, all of these things mean that your experience when you get cancer is likely to be worse. So we spent a lot of time really thinking about how do we partner with communities, with the right organisations, with people directly to address some of those things. And that's the work that you've seen. That's what we're doing.
Equity is a buzzword that people are throwing around. So what does equity look like from the perspective of Macmillan?
So for me, it's about everybody in the United Kingdom with cancer getting the best possible care experience. And so it's not about everybody having the same experience, because everybody's experience has to lift up, because we are falling behind the rest of the world. Outcomes in some types of cancer are 20 years behind others in Europe now. That's an appalling state of affairs I think people in the UK are shocked by. And so we need to lift everybody's experience, and we need to do that in an equitable way, because the gaps between people who have access to the very best care and those people that don't are widening all of the time. And I think with the huge pressure that the NHS is under at the moment, with rising instances of cancer, with increasingly complex treatments being available, the risk is that gap just gets wider and wider and wider. We've just done some work as an organisation looking at our own strategy and have involved lots of people in that, lots of people with deep expertise, whether that's from their own lived experience or from learnt experience, lead academics, clinicians, people who work in the system. Everybody thinks the gap between the best and worst experience is going to continue to widen. So the job for an organisation like Macmillan is, what can we do differently to mean that innovations in healthcare are genuinely equitable? That means designed for the people that are least likely to benefit first, and then it will benefit everybody, rather than what happens now. We see everywhere, we get really excited by an incredible new treatment or a new breakthrough or a new technology or a new way of delivering care. We work out how we can get that to some people, often the easiest people to get it to, and then later on we struggle to think about, now how can we now go back and see how we could get that to the groups that aren't benefiting? It just doesn't work. So we've got to really develop the skill of how do you design with equity in mind from the beginning. And that's one of the areas, there are a few which we can talk about, but that's one of the areas that is a real focus for Macmillan, not the innovation. We think that, the kind of tide of innovation in cancer is coming, and we're pleased it's coming, and that we don't need necessarily to do more of that. What we need to do is make sure that as that innovation comes and builds, that it's designed equitably so that it's fair. so that people across the UK, whatever their experience, whatever their wealth, whatever their postcode, whatever their identity, experiences those benefits in the same way, fairly.
It's interesting that you mentioned those new sets of innovation. How do we balance latest in research and UK's extensive data and transforming that into better care for people with cancer across the UK?
Yeah, so there's a risk. We want to be excited, don't we, about those opportunities, and I can't be really excited about them unless we understand how it is that they're going to work for the most marginalised communities. And often that thinking is not happening. And therefore, for instance, the cultural competency of the workforce that are delivering it, or the relationships and trust base with the communities that there needs to be in order to get people to turn up for screening. I mean, like, if we stopped all innovation today, let's just imagine where we are today is as good as it's going to get, and then just applied what the best care that people get in the UK now to everybody, that would save tens of thousands of lives. And we can't do it. So many organisations have been trying to do it. It doesn't happen. And so we have to see that as something which needs radical reform. Like, we need to inspire something totally different in care delivery for us to feel confident and excited about all those things that you talk about. And I am excited about for instance, AI and the advances that might bring in terms of how we can target therapies, or how it might be that we can identify at-risk populations, or how we might be able to free up capacity in the workforce, go on and on and on. I am excited about that, but I feel like I'm always the voice in the room saying, stop, before I allow you to get really excited about this, explain it to me. Like, how is that going to benefit these communities that have missed out time and time and time and time again in all the other innovations that have happened over the last decades? And often people will say, well, we're working on it, we're thinking about it as an afterthought. It's just not good enough. So one of the things that lies at the heart of it for me is about how do you bring people who have lived experience of marginalisation, of cancer, into conversations with entrepreneurs and innovators early enough. So one of the things that Macmillan does is we have an impact innovation fund, which is where we invest in health startups. But one of the things that's key to that is the reason we do it is because we want to bring Macmillan's experience, and really the experience of people with cancer, into the cancer innovation and startup space, because we think it will mean that innovations as they come through are more equitable, because we will invest money in startups, but we have conditions about how those startups have to work from an equity perspective. So we're not, some organisations invest for financial return, we're investing for social return, and saying actually, and the entrepreneurs we're working with love it, because actually they get access to healthcare professionals and people with cancer, and that really helps them develop something that's better than it would otherwise have been. So that's an example of some of the work that we're doing to try and tackle the...
Will you argue we need like a threshold of innovation? Now the attention should be pumping more focus and resources on implementation.
Yeah, I mean, really, I couldn't put that better myself. So everyone's drawn to the glitter of innovation. And actually, the thing we're really bad at is implementation in the UK. So it's not that, and you could name any problem in cancer, we could list thousands of them. I could probably tell you a place somewhere that has done something that is tackling that and it's making serious inroads. Nobody else knows about it. Nobody else has adopted it. No one else can. And there are lots of reasons for that. It's about capacity of the workforce. It's about understanding about how implementation happens. It's about communities of practice and knowledge. It's about how budgets are held. There's so much stuff that goes into that. But if we could put as much effort and if we could generate as much excitement about implementation as there always is about innovation, then we'll be a lot further on.
From the perspective of non-clinical burdens for patients with cancer, where's your head at, and possibly potentially steering the organization in that line?
Can I give you a couple of examples?
Yes.
They illustrate it really well. So, for instance, one of the things you'll see when you look at the data about where cancer outcomes are the worst and where experience is the worst is that there is hubs of a really poor experience and outcome around the coast of the UK, particularly in deprived communities around the coast. Also happens to be areas where there are big fishing communities. And so Macmillan is working with the Fisherman's Mission, which is a charity that works specifically with fishing communities, to build community projects where fishermen who are out, can have on their time let me rephrase that, in times that suit them. Information, conversations, build their confidence about cancer, have healthcare professionals come to them. So cancer incidence in those communities is high. Worse than that, cancer outcomes once diagnosis has happened are low. And the reasons are complex, and they are about, it's a kind of very, it's a population where they're sort of out at sea for long periods of time, macho population, massive, most very large majority male, not very confident in speaking about health conditions or showing vulnerability. The idea of wearing sunscreen, and then add into that, even if you've got a symptom that you're worried about, so maybe you've got a lump and you're coming into the port and you're like, okay, I'm actually going to try and see my GP. I've got 6 hours before the boat leaves again, or I've got 3 days. The chances of being able to get an appointment in that time, or even if you get the first appointment, being able to get the follow-up. And then because so many people in the first things people hear is that their colleague had cancer and died. So then the narrative becomes, we don't want to talk about cancer because nobody survives cancer, because in that community, that's true. That's what it feels like. So there aren't stories of hope. There aren't the stories of people who went to screening, got something picked up, came back, actually went on to have 30 years of a career. And then add to that, if you start treatment or you have a diagnosed condition, which the reason it came to my head when you talked about the Northern Lines example is that some skippers won't take you on the boat because they're worried about insurance. Soon as you've got something and so then you're the only source of income for your family, and you're not going to want to get diagnosed because you're not going to. So all these issues are complex and they're merged. So the first thing to do is to be around and build trust and work with organisations that already have trust in that community and to keep showing up. The second thing is about then working with healthcare professionals in that area to come to them on their time. So things like district nurse visits, dentistry appointments, all the things that we know matter, coming to the dockside at times that they can do. And over time, it's not fast, but over time, then the health of those communities changes. And it's that sort of work that will make the difference, because it means that then the stories, when you hear the stories of people now starting to say, well, I went to this group and I talked about my symptom, and actually they were able to get me an appointment with a nurse the next day, and I was really worried about it with skin cancer, but now I've had it taken off, and now I always wear sunscreen, and then other people talk about that and they hear about that and it's a positive story. So that's the sort of work that we need to be committed to as a society, to bring people in and to meet them where they are with the things that they need, rather than be like, this is one size fits all, this is what it means, this is how you must be diagnosed, this is how you must get an appointment with a GP, this is how you must be treated. We've got to flex the model to understand that different communities have different needs, and that's just an example of one of them.
So what do you consider the quick wins that the UK can celebrate, and what in this context, in all of these major challenges that you've mentioned?
So I think some of the quickest wins are to sort of raise it up and talk about it. So I was really pleased to see in the Darcy report that actually the inequity is called out as a real issue, because there's been a long time where we haven't been able to talk about it or talk about the data on it. So I think that's the first thing, because if you can't see the problem, you can't fix the problem. I think the second thing is about, as we've talked about implementation. So communities of practice that are around implementation and adoption. I think the sharing of where the very best work is happening and then supporting people to implement it. We've done some work in Glasgow over the last decade that now have a programme which is rolled out across the whole of Scotland for people with cancer. That model, community-based support for people proactively from the point of diagnosis, would be transformative. But it requires another key change, which is for us to think about the sort of budgets and the economic benefit of healthy populations to not just be about an NHS or a hospital budget, we have to think about the whole, because the benefits to getting this right for the fishing community or for any community, there's a huge benefit to society, but it's not to one budget. So we've got to think about those things in the round.
What can you say about the lessons that the organization learned about the true state of cancer intervention in the UK in the context of COVID?
So I think we all learned a lot in COVID, and some of it was good and some of it was bad. And the good stuff we learn is that you can stand up clinical trials really quickly. You can galvanise a whole population around an issue. You can get communities to work and support each other. And if you take some of the shackles off that stop that happening normally, that actually people will self-organise. All of those things are really important. It gave us, if we took that sort of level of focus that there was on COVID and applied it to cancer, and that cancer causes much more harm, harm, the benefit would be huge. We also learned that when you go very fast, you can exacerbate inequity, which is the conversation we were just having. That's exactly what happened in COVID. We had a kind of dictatorial that, here's the vaccine, we've got the vaccine now, that's job done, rather than thinking about actually what are the relationships that we need to make sure that everybody who will benefit from the vaccine has the vaccine. What are the mechanisms that we'll need to deliver that? Very similar to the work that needs to be done and is being done around cancer and cancer screening in terms of populations where there isn't high trust. So I think, I've talked about the positives. I think the negatives are, the other negatives are that cancer got derailed. Cancer care got derailed by a lot of what was happening in COVID. So routine kind of scans were missed. We're still catching up from people who now maybe have fewer treatment options available, from people who've died of their cancer who wouldn't otherwise have done, from people who've missed out on screening so their cancer's been caught much later. And all of that is a legacy of COVID. And when we were taking the decisions in that kind of very intense period, it was very difficult to weigh up the consequence of diverting so much resource to COVID at the cost of some of the regular stuff that needed to happen for cancer, even though lots of cancer stuff was protected. We can see the impact now. So waiting times are at the highest in the UK they've ever been. That's really impact on people's lives. It's an impact on their outcome and their survival. It's massive impact on their mental health. Waiting for a diagnosis, to be waiting for results, to be waiting for follow-up. All of those journeys now are much more prolonged than they should be. And although we're seeing an increase now in terms of the number of people coming through, we're nowhere near caught up from where we were before COVID. And let's remember that before COVID, we were not where we wanted to be as a country. So we now have set this bar of, if we can just get back to where we were pre-COVID, but COVID, my organisation and others pre-COVID were saying, this is nowhere near where we need to be if we really want to deliver world-class cancer care within the UK. So there's a big job still to be done.
You are at the Global Congress. What are you already intrigued about? And what are your quick take-homes?
The thing that's been most inspiring has been hearing how many people are facing into the same challenges and are designing solutions that are similar or that are related, and how much opportunity there is to work internationally, to really learn. All that learning that I talked about that we're not very good at even happening within the UK, actually we need to be doing that internationally. So it's been really good to connect with different not-for-profit organisations, different health organisations, different governmental organisations, to think about where we've got learning that's relevant. But most importantly, I'm here to learn from others, and I've already seen a few things where I think actually we could probably, if we partnered with that organisation, accelerate our learning in that space. And that's exactly what this is about. And the joy of being at a conference like this is people are here to share and to learn. So those conversations can happen in a very intense period of time, and therefore hopefully accelerate what we're able to do.
Yeah, any last remarks for me?
I'm feeling hopeful that it is possible, that this is a moment now where the congruence of huge excitement about innovation, both in technology and treatment, and increased awareness and understanding of the impact of inequity, and more of a conversation about the challenges of implementation, and much more of a understanding and commitment to the importance of patient voice, lived experience right at the heart of decision making. All of those things I feel could come together to make the next 10 years a real moment, a legacy moment for us, where we absolutely turn the tide of the story on cancer to be one which is about positivity and about hope and about living well with and great care experiences of people with cancer. So I am feeling optimistic, but aware of how hard the job is in hand, but ready for Macmillan to play our part.
Thank you so much. That was beautiful.